Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Dr. Prasad Kilaru. Dr. Kilaru attended medical school at Guntur Medical College in India. He conducted his internship and residency at Bay State Medical Center in Springfield, Massachusetts. He did a fellowship at the University of Southern California in Los Angeles. Dr. Kilaru is board certified in general surgery, plastic surgery, and hand and microsurgery.
What I wanted to do is kind of give a brief overview as to how wounds form, what are the factors that kind of make it more likely that a wound will form, what are the things that we can do to get a wound to heal quicker, and then what are the common types of wounds, and really kind of concentrate on the diabetic wounds because they're the ones that we see quite a bit of, and how to manage them and what to do for them. So wound care or wound problems have been around forever. Almost over 4,000 years ago, there are documents about wounds and how to take care of wounds back in the Egyptian papyrus, Indian literature, Greek, European literature, all have some theses, treatises on how to take care of wounds. And back in the old days, they knew the concept of being gentle with the tissue, bringing the edges together, protecting the damaged tissue, and even various types of dressings that were used. Unfortunately, in the Middle Ages, all that was lost, and we had some of the more barbaric techniques that came into vogue, like leeches and boiling oil and hot cautery and things like that. As medicine advanced, we've gone back to some of the older techniques while incorporating some of the newer techniques, and I'll actually talk about leeches later on. Some of the big names in wound care, John Hunter was a surgeon who experimented with putting limbs back on once they were cut off. Lister was one of an English surgeon that figured out that you shouldn't do autopsies and then go deliver babies and things like that, which increase the risk of infection, and one of the first pioneers of washing hands, starting with washing hands and then progressing to the asepsis that we use in the operating room and such. And more recently, in the 20th and 21st century, a lot of the work's being done in the cellular level, looking at growth factors, looking at different special compounds and other mechanisms to try and improve healing or improve the factors that are kind of not working properly in a wound that's not healing properly. So what is a wound? Well, Webster's defines a wound as an injury to the body that occurs because of a laceration or a breakdown, and it can occur in the skin, but it can also occur in other body parts, inside the mouth or any other mucosal surface. Depending on the size and depth of the wound, there are different ways in which we classify wounds. So one way to classify it is depending on how deep it is. So stage 1 is almost like a pre-wound. It's not quite ready to be a wound yet, but the tissue's kind of damaged and not totally healthy. Stage 2 is when the wound is involving the skin, but hasn't completely gone through the entire thickness of the skin. Stage 3 is when it's gone through the thickness of the skin, but hasn't really reached any vital structures. And stage 4 is when it's reached vital structures like muscle or bone or anything like that. So that's one way to classify wound. Another way to classify wounds is what type of wounds they are. Are they an acute wound, meaning something that kind of happened in a relatively short period of time, or a chronic wound, a wound that's been around for a long period of time. In most patients, the acute wounds are surgical wounds, traumatic wounds. You fall, you cut your hand, we put stitches in to fix it. That's an acute wound. There's no problems with it. It should usually heal up without any issue. A chronic wound is when there's some underlying factor which is preventing it from healing like it should. And the definition of a chronic wound is a wound that's been around for more than 6 weeks. Now, if somebody has predisposing conditions, we don't want to wait 6 weeks. We want to treat them sooner. So if you're diabetic or if you've had radiation or some of these other things I'm going to talk about, you don't want to wait for the 6 weeks to say, now it's a chronic wound, we need to take care of it. You want to come in sooner so that we can prevent it from becoming a chronic wound. And the 3 common chronic wounds we see are diabetic ulcers, pressure ulcers like bed sores, and venous ulcers, or ulcers related to poor circulation. So on the right-hand side is an example of an acute wound. That's just a cut on the hand. And we're able to put that together with stitches, and that usually heals without any problems. On the left-hand side is a chronic wound. This is a bed sore from laying in bed for too long a period of time, and that is not going to heal very quickly. And there are things that we need to do to either prevent it or to help it heal a little bit faster. So to understand chronic wounds, we should understand how a normal wound heals. So when you get a cut, the wound goes through several stages before it's completely healed. Typically, there are 4 stages that are involved in wound healing. The first stage is called the hemostasis stage, then the inflammatory phase, the fibroblastic phase, and the maturation phase. It's not as important to remember what the stages are, but to kind of realize what the timeline we're looking at. If you look, the whole process for a wound to completely heal is almost a year. For a scar to completely mature is almost a year. The first few weeks is when it's healing and getting better, but then for that wound to get as strong as normal skin or close to the strength of normal skin, it takes up to a year for that scar to mature. So in a chronic wound, that normal cascade, that normal pattern that's supposed to happen doesn't happen. So a wound that should go through the different phases gets stuck in a phase, depending on the type of wound, either in the fibroblastic phase or the inflammatory phase, and it doesn't heal. And what we need to do is figure out why it's stuck in that phase, which phase it's stuck in, why is it stuck in that phase, and what can we do to kind of help it move along, get back to the normal healing pattern. So there are different kinds of chronic wounds. Pressure ulcers, like I said, the bed sores, are probably one of the most common variety. Vascular ulcers related to poor circulation. Now there are 2 types of circulations. There's arterial circulation, which is blood that's going from the heart down into your hands and feet and toes. And if the circulation is poor, there's not enough blood coming down there, that may cause an ulcer to heal, a wound to form or heal slowly. The other is venous circulation, the blood that's in the toes getting back up to the heart. And if that's not good, then that's also going to delay the healing of the tissue. And next is diabetes, the metabolic causes. The diabetes mellitus. And again, between the vascular ulcers, the pressure ulcers, and the diabetes, they account for almost 80% of the chronic ulcers that we see. Now, we also see other versions because of infection, because of autoimmune diseases such as vasculitis and cancers and burns, radiation, and the like, but those are relatively small. The majority are the first 3 categories that we were talking about. What are the factors that kind of promote this chronicity, or what makes it more likely that the wound's going to be chronic? Most important is nutrition. Now, like anything else, if you don't have fuel, you're not going to run the car. And the fuel for the body is nutrition, protein, calories, vitamins, all that stuff. Now, the body is very good in prioritizing. So the first priority is to make sure the brain and the heart and all the organs are working. The second priority is to make sure that your muscles are working so you can get to where you need to. Unfortunately, the wounds are kind of low on the priority list. So if your nutrition is not up to par, the first area that the body kind of takes away from is from the wounds in the peripheral area. It wants to keep the core healthy. So we need to make sure that we have good nutrition and proper nutrition. I mean, I can't tell you the number of times we see people who are overweight but who have poor protein levels or poor vitamin levels because they're eating, but they're not eating the way that they're supposed to. Their protein levels aren't good, or some of the basic stuff that they need to heal the wounds aren't where they need to be. The second most important thing is oxygen. If there's not enough oxygen going to the tissues aren't going to survive. And more importantly, they're not going to heal. And again, like I said, the oxygen can be 2 parts, the blood coming down to wherever the problem is and the blood leaving from wherever the problem is. Both those areas need to be working properly. Third is infection. If there's an infection in the area, obviously that's not going to heal because the bacteria are fighting with your own tissue for the food and the oxygen that's coming to that area. And more often than not, especially in a compromised area, the bacteria is going to win compared to your own tissue. So that tends to make things get worse. Other conditions, as you can see down the list, diabetes mellitus, there's cancer. Again, cancer is going to fight out your own tissue. Usually it's going to win as far as trying to get the tissue, trying to get the nutrition. Anything that decreases your body's own ability to heal, immunosuppression mainly, chemotherapy, steroids, radiation therapy, all of those decrease your ability to heal. So those will tend to slow down your healing. And then mechanical factors, especially for bed sores, very important. If you're laying on a bony prominence, on your back, on your heels, putting pressure on them, that's not getting enough blood into that area, and that can cause damage and the wounds to break down. So again, just kind of reiterating what we said, oxygen, nutrition, infection, diabetes, these are the four main things that we worry about. Other things, smoking, any lecture in medicine will always throw smoking in there. But for wound healing, it's extremely important. There were studies that showed that a single cigarette, when we look at fingers, a single cigarette decreases the blood flow to the fingers by 40%. Right? So same thing with the toes. A single cigarette will decrease blood flow by 40%. So if you have an ulcer on your toe, intuitively you will know that you're not going to heal it as well if you're only getting half the blood you normally would. And if on top of that you throw on diabetes and poor circulation and everything else, it's going to make it worse. The other things that are important are what we do to the person. The first one I showed you is problems that are inherent to the person. The second is what we do to the person, the type of dressings that we use. Any other problems, any other chemicals that we're using, chemotherapy or radiation or other medication that you're taking. If you're taking steroids for kidney failure or steroids for autoimmune disease or some other problem, arthritis or any of those things, they're going to affect other areas too. They're going to affect how the wound is healing and such. So how do we take care of that? Well, we address those issues that we know cause problems. So we monitor the nutrition, make sure we improve the nutrition. If somebody's on infection, we put them on antibiotics, address their medical problems. There are studies that show that diabetics treated versus untreated, very significant difference in how quickly they heal their wounds. Same with the renal failure. If you have kidney failure, somebody who gets dialysis twice a week as opposed to 3 times a week, very different in how they heal the wounds. Somebody who's got poor circulation, if we can improve the circulation, that's going to definitely make the healing better. Locally, for the dressings, what do we need to do for the wound? If the wound is not clean, are we using the proper kind of dressing? Are we cleaning the wound like we should? Are we getting rid of all of dead tissue? If there's a lot of swelling to the tissue, are we addressing the swelling? Are we decreasing the swelling or not? And then some of the more fancier modalities that we get into, so whether it's surgery or some of the fake skin or skin substitute or special growth factors and chemicals that we can use to kind of get the wounds to heal. So the principles are find out what the cause of the wound is, treat the cause, support the rest of the body, and treat the problem locally. And for each problem, that's pretty much how we address it. Because anybody who gets a wound, if everything is working properly, we never see them. If when they're not healing properly, then there's something going on. So first we need to figure out what's not working instead of just treating the local problem. So I always say this, God does the work, I take the credit for it. But the thing that we need to do is make sure that we get the body where we need it to be. And again, for nutrition, making sure the protein and calories are where they need to be, making sure that we're giving enough vitamins, nutritional monitoring. There are blood tests that we can do to see if the protein levels are where they need to be, if the vitamin levels are where they need to be. And if not, there are supplements that we can give, again, depending on what's deficient, whether it's orally, if somebody's outpatient, or if they're in the hospital, we can give it through the IV or through a feeding tube to improve the nutritional status. Infection control, again, very big, very key. We want to make sure that the wound is not infected. Now, sometimes there may not be a full-blown infection with it being red and pus coming out of it or anything like that. But if there's bacteria that are just kind of living in that wound, they're doing enough damage that they're preventing it from healing, but not so much that they're creating an overall infection. So we need to identify that, clean that kind of low-grade infection off also so that it doesn't inhibit healing. And obviously look at more specific things like if there's infection involving the bone or the muscle, getting rid of that infection before we move on. And then a lot of times that getting rid means surgically cutting out that tissue that's not healthy and not surviving. Second most important thing is we need to make sure that the blood supply is adequate. And all routes, whether it's the antibiotics we give, whether it's the nutritional supplements we give or anything, they get to the wound through the blood. So if there's not enough blood going down there, it's not going to work. So what we need to do is make sure that there is adequate blood going down there. And we do that by, again, evaluating what the vascular status is, evaluating if there are any blockages. And it's like plumbing anywhere else in the, in a house or in the body. We find a blockage, we try to open up the blockage. If we can't open up the blockage, we go around it with a bypass. If we can't do any of those, then we do other modalities to try and improve the circulation, whether it's hyperbaric oxygen, which I'll talk about, which increases the concentration of the oxygen in the blood vessels that are working properly to try and improve the healing in that area. As I mentioned, arterial circulation is the blood coming down into the foot. The venous circulation is the blood going back up into the foot. Now, the arterial circulation is much more prevalent, and people are more aware of it. My artery's not working. Oh, I walk for a while, my leg hurts, or I've had the same problems in my heart or in the blood vessels to my brain, and what have you. The venous circulation is a more indolent problem. It's something that not everybody, even not a lot of physicians, really know how to treat well. In fact, even us in the wound clinic as the wound care center experts, we don't have a very good treatment for it. A lot of it is prevention, is to prevent the wounds from happening, prevent the swelling in the legs from happening. And we do that with compression stockings, with special devices to decrease the swelling in the legs, to prevent the wounds from breaking down. So which brings us to the dressings. A dressing is basically any kind of device we use to cover a wound. Now, the function of a dressing is to provide optimal environment for the wound to heal. Now, at different stages, there are different types of dressing you may need. If you take a typical wound that happens after infection, initially there may be a lot of drainage and there may be a lot of bacteria in the wound. So we need to use a kind of dressing that will suck up the drainage, which will kill off the bacteria. As the wound cleans up, the drainage comes down. So if you still use a dressing that's sucking up a lot of drainage, then the wound will tend to dry out too much. So then you have to switch to a wound that will to a dressing that will keep the wound moist so it doesn't completely dry out. And then as the wound starts to heal and the skin has kind of regenerated, it's still very fragile skin. It's very easy for it to break down once again. So you want to use a different kind of dressing to more protect the skin. So at different stages you use different dressings, and sometimes we run into this issue where somebody's been doing a dressing initially and they keep doing that for 2 months, 3 months, when in reality they should have changed to a different form as the wound is evolving. And as far as the type of dressing, as I mentioned, depending on where the wound is, how much drainage there is, how the surrounding tissue looks. If the surrounding tissue is very macerated or very tender, or in an area where it's difficult to get tape on, for example, then we have to use different kinds of wounds. And obviously we also have to look at cost. Some of the really interesting stuff that's coming out there, because it's new, tends to be more expensive. And that is also a hindrance to kind of get us to where we want to be. So we look at all of those when we try to figure out what's the best kind of dressing that we can apply for these wounds. Now, debridement is a technical term which basically means removing dead tissue. And there are a couple of different ways in which we can do that. The one way that's the most common is surgical debridement, meaning we take a knife or a scissors and cut out the part that's obviously dead or looks dead or doesn't look healthy. But there are other ways in which we can remove the tissue. One is to use chemicals. Enzymes that eat up dead tissue, don't necessarily damage living tissue, but eat up the dead tissue more often. Or we can use mechanical debridement, like a whirlpool or a hot tub, where the water is beating the tissue around and kind of getting rid of anything that's flying around. One of the things that we have used, and I have a picture somewhere, is maggots. And maggots actually eat up dead tissue. They don't eat living tissue, and they eat dead tissue. And for wounds that are extremely painful and extremely difficult to treat, that's one option to use. Again, going back to old barbaric methods that we found work, but we use it in select situations. Once the wound gets to the point where it's relatively clean, then we have two options. We can let it heal by itself, or sometimes we try to accelerate that healing by doing surgery to close it. And we use what's called a reconstructive ladder, meaning we try to do the simplest thing first and work our way up to the most complex thing. And the simplest thing could be letting it heal by itself, or cutting it out and pulling the rest of the tissue together so that you have healthy tissue on each side to close up, or doing skin grafts, taking skin from another part of the body and using that to cover, or doing more exotic things like taking part of muscle or skin or bone and moving it over to close that defect. And so it could be something as simple as a 15-minute procedure in the office to as complicated as an 8 or 10-hour procedure in the operating room, again, depending on what the needs of the person are. And finally, if none of these work, amputation is always an option. In our mind, and in most wound care settings, amputation is considered a failure because we've tried to save the limb and we've done everything we can to try and save the limb and it hasn't succeeded. But sometimes a patient can actually be more functional with an amputation, especially if you have somebody who has a lot of contracture. The limb's kind of stuck in a very bent position where taking care of them and such is not possible, or you have a really painful wound that's not progressing. By amputating that part, you take the pain away, they're able to be more functional, walking and things like that. But again, even then, it's our last option once we've tried everything else and it hasn't worked. As I mentioned, hyperbaric oxygen is one of the modalities. It's a relatively new modality here. It's been around for about 20, 30 years, but it was mostly in the Navy because they used to use it for deep sea divers and things like that. Now, hyperbaric oxygen, what we do is we take a patient and we put them in one of these chambers, and we increase the pressure in the chamber to 2 atmospheres, which is twice the pressure that we have at sea level. And by increasing the pressure in the chamber, we're increasing the amount of oxygen molecules that are there, even if they're breathing room air. We have them breathe 100% oxygen, so we're basically increasing the amount of oxygen they're breathing by about 10-fold. And by increasing the oxygen they're breathing by 10-fold, you dissolve more oxygen in the blood, because in the blood, oxygen is carried through 2 ways. One, in the blood cells, and second, dissolved in the actual liquid of the blood. And by increasing the pressure and increasing the amount of oxygen delivered, you're increasing the oxygen that's dissolved in the blood by more than 10-fold. So you're able to get more oxygen to the tissues, and that's been found to significantly improve healing in specific kinds of wounds, especially the diabetic wounds, wounds where there's infection to the bone, and things like that. And it works really well in those situations. And that's something that we've started here at Washington Hospital about a year ago. So we've had a wound clinic for about 5 years, but for the past year, we've also started the hyperbaric oxygen treatment, and we found some very extremely successful results with some of our more complex wounds. The other thing that we've also started doing is to use growth factors. As I mentioned, in the late 20th and early 21st century, a lot of research is being done in growth factors. When I showed you that first picture with the different cascades, the 4 stages of the wound healing, well, the second stage, which is the most critical stage for the wound healing, depends on these growth factors, or basically little hormones or enzymes that the body produces that stimulate the wound to heal. And in a chronic wound, the theory is that those growth factors aren't there in sufficient quantities, so the wound's not stimulated to heal. So what they've been able to do is isolate these growth factors and figure out which one is the one that really kickstarts the process again. And then we're able to deliver those growth factors either as a spray or as an ointment onto the wound itself, and again improve the likelihood of healing those wounds. Other tissues, again, the apograft and the dermograft are fake skin. So they're skin cells that are grown in a lab. And these skin cells, because they're very early skin cells, have a high concentration of the growth factors again. And they're supposed to help speed up the healing process. And in normal wounds, without any treatment, we do the local dressings that we used to do 20 years ago or 30 years ago. The healing rate, say, was 10% or 15%. With these growth factors and with these tissue engineered products, they go up to 60 to 70%. So 6-7-fold increase in the likelihood of healing these wounds with these newer techniques. And then, as I mentioned, whether it's using maggots or leeches for some of the more complicated wounds. The maggots clean up dead tissue, the leeches get rid of excess blood. So if you have a venous problem where there's too much venous blood in the tissue, the leeches help in kind of getting rid of some of that venous blood to allow the circulation to reestablish itself and improve the healing in those situations. One of the other modalities that we use quite a bit for some of the more complicated wounds is what's called a vac therapy, or a vacuum-assisted closure device. And in this situation, what we do is we have a wound like this. We put this foam in the wound, and we connect it to a negative suction device, almost like a vacuum cleaner. And that negative suction device sucks on the wound and collapses the wound on itself. It also increases the blood flow, or stimulates blood cell generation, increase the blood flow into that area, and typically has been found to heal the wounds in half the time compared to not using a vac. So doing regular traditional dressing changes versus using the vac speeds up the healing by about half. So when we're looking at these treatments, we do them in combination. We don't do one, oh, that didn't work, let's do number 2 or number 3. We look at what the problem is, we try to fix the problem, and at the same time look at trying to combine 3 or 4 of the best modalities for that patient and see what works best. So I wanted to take a few minutes to talk about the chronic wounds, the wounds that we see most often. And as I mentioned, pressure ulcers, venous ulcers, and diabetic ulcers account for between 70 and 80%. And just the care for these wounds, not the time lost, not anything else, just the care for these wounds is about $1 billion a year. And the sad part is the majority of these can be prevented, either through education or proper care and things like that. So that's kind of my area of where I'd like to see some change being done. Pressure ulcer. When you put pressure on an area, so both of these are on the heel. So this is from the heel, this is from the heel, this is from the side of the hip. So whenever you're laying down or putting pressure in any area, that pressure causes decreased blood flow between the bone and the skin. So if you say you're laying down here, skin here, hard surface here, and if there's bone here, between that bone and the skin, that tissue is being compressed. And there's not enough blood going into that tissue. The blood pressure, 120 by 80, what everybody wants to be, is the pressure that's in the big blood vessels that are coming out of the heart, which is what we measure when we take the blood pressure cuff and things like that. As they start going from the big blood vessels down into the capillaries and the veins, the blood pressure comes down from 120 over 80 to about 30, 40 millimeters. When you're laying down on the bed or on a hard surface, the pressure between the bone and the hard surface can go up to 60 or 80 millimeters. So if you can imagine, the capillaries are open at 30 to 40 millimeters. If the pressure goes up to 80, those capillaries close up. When those capillaries close up, there's not any blood going to that tissue. And if it closes up for a long enough period of time, that tissue is going to die because it's not getting any blood. And what we found is typically it takes about 2 hours for the tissue to die. So if there is pressure in an area for more than 2 hours, that tissue can die, which is why we want to move. Now, our body is designed where we unconsciously or subconsciously move. So all of you sitting here, even if you're sitting for 2 hours, you'll kind of move subconsciously, so you're not putting pressure in the same area. You'll kind of move to one side, or you'll move from one foot to the other foot, or what have you. So you're not putting pressure in the same area all the time. But if you are paralyzed from a stroke, or from a fall or surgery or anything like that, or if you're demented, older, and can't move, or really sick in the ICU, on a ventilator, where you can't move by yourself, all those predisposed because you're not able to do the movement, and that can lead to breakdown in different areas, which is why we need to move on a regular basis, and on patients who can't move by themselves, have some mechanism to move them. And you can see, depending on how you are, if you're sitting, it could be the buttock or the lower back area. If you're laying on one side, it could be the side of the hip, the side, side of the ankle, the head. If you're laying on your back, it could be the buttock again, the back of the heel, the back of the head. If you're laying on your stomach, it could be the elbows, the knees. So depending on where you're laying, you can develop pressure ulcer pretty much anywhere in the body, because there are many areas in the body where the bone is very close to the skin and there's not a lot of tissue in between. Now, Again, going back to that classification I showed you earlier, depending on how much damage there is, skin, fat, muscle, bone gets damaged. Now the muscle, because of the activity that it does, needs the most blood supply. The skin needs the least blood supply. So when you get a bed sore, more often than not, what you see at the top is really the tip of the iceberg, because the skin, not as much of the skin dies, more of the fat and the muscle dies because it needs more blood supply, and if it's not getting blood supply, that dies quicker. So it's very important that we don't wait for things to happen at the skin level, but monitor that and change positions very frequently. And again, unfortunately, depending on the patient population, if you have the elderly patients or demented patients or patients who've had a stroke, soilage from urine, feces, if they're incontinent, all of that, again, damages the skin, makes it more prone for those breakdowns. So a lot of it we can do with prevention by making sure that they're being changed on a regular basis, they're being moved on a regular basis, that the nutrition's good. Again, if you have this patient who's had a stroke and can't really say and is not eating regularly, their nutrition levels are going down. They have soilage because they're in a diaper and that tissues area, and they're not moving. So all of these kind of come together and form this problem. And once they form the problem, it takes an exponential amount of time to be able to fix those, because the underlying factors are still there. They still have problems with soilage and movement and all these other things. So prevention is a lot easier than trying to fix the problem after it happens. With the arterial ulcers, there's, as I mentioned, poor blood flow. So the most important thing that we can do to improve these and get these to heal is to improve the circulation. And that, as I mentioned, can be through bypasses, can be through stents, just like they do in the heart, or it can be to try and get rid of any of the dead tissue that's there and see what we can do. Now with the venous ulcerations, it's more of a problem because the return flow back to the heart is not working as well. And you have edema or swelling in the legs related to that lack of return flow. So the most important thing that we can do is control that, that swelling and the edema. And some of it is very simple. It's keeping the legs up above the heart to decrease the edema, let gravity help, using compression stockings. But the thing I tell my patients is with these problems, unfortunately, unlike with arterial problems where we could do a bypass and increase the blood flow or things like that, there's no fix, there's no cure. We support it till it heals, but if you have a venous ulcer, if it heals, but if you stop using the compression stocking, stop keeping your legs up and things like that, it will come back. 100% of the patients, I tell them, this is something you have to do for the rest of your life. Because if you stop doing it, the ulcers will come back. Not right away, maybe a week, a month, a year, but they will come back because the underlying problem cannot be fixed. Now diabetes, this is a bigger and bigger problem. Worldwide, as I mentioned, it's 3%, it's expected to go to 4.5%. But in diabetics, the issue that can be problematic is a diabetic foot ulcer. About a quarter of the patients in their lifetime will get a foot ulcer. And if you have a foot ulcer, you're at 50%. You're twice as likely to end up with an amputation, end up with a real problem, 15 times as likely to end up with an amputation. Now, where'd it go? This is a very telling statistic, 40 to 70% 5-year mortality. By comparison, that means what if you're a diabetic and you end up with an amputation, there's a 40 to 70% chance that you will die within 5 years. To put that in perspective, the 5-year mortality for diabetic patients who end up with amputation is more than lung cancer, than breast cancer, than colon cancer. So if you're a diabetic that needed an amputation, you're more likely to die than if you were diagnosed with lung cancer, colon cancer, or breast cancer. That's how serious it is, and that's how important it is that we try to avoid an amputation. And obviously the way to avoid the amputation is to avoid the first step for that, which is the pressure ulcer. The cost for diabetes care, $132 billion. 90 billion in direct costs and 40 billion in lost productivity and wages. For a single foot ulcer, and this is a couple of years old, so now it's even more expensive. For a single foot ulcer, it's 14,000 to 20,000, and an amputation, depending on the level, is between $20,000 to $60,000. the cost of the system, not to the individual person, but the cost of the system, whether it's insurance or et cetera. And obviously, productivity, quality of life, we're not even including all of that in these statistics. And again, as I mentioned, if you are diabetic, if you have a foot ulcer, you're 15 times more likely to get an amputation than if you're non-diabetic. Now, there are many reasons why foot ulcers occur in diabetes. The three common things is ischemia, which is poor blood supply, because diabetics, their circulation's poor. Not only the big blood vessels, but the tiny blood vessels don't work as well as they should. Neuropathy, sensation, you can't feel. A lot of times when the diabetes isn't under control properly, you get diabetic neuropathy where you can't feel or the feeling is off. You may have a burning type sensation or a numbing sensation where I've had patients that had a pebble get caught in their shoe and they don't realize, and they've been walking around with that pebble in the shoe for a couple of days, and next thing you know, that creates an ulcer. Infection. Diabetics, again, especially those that aren't controlled properly, their blood sugars are high, meaning there's more sugar, more food for bacteria in their blood than in other patients. And if that's the situation, then that's going to make it easier for those bacteria to thrive and grow and multiply. So what we are looking at is these three factors, but these other factors are also important. Callus is basically extra scar formation over the skin, which prevents it from healing properly, prevents the sensation from coming back properly. The toenails, because they're not treated regularly. Fungal infections, which normally don't occur in normal individuals, tend to occur at a higher incidence in diabetics because, again, their immune response isn't as good and they can't fight those infections as easily as normal patients could. With the blood vessels, the problem is both with the large blood vessels as well as the small blood vessels. The large blood vessels are the one where you get the atherosclerosis, the plaque buildup that you see all the ads for. The small blood vessels are the blood vessels, the capillaries and the small venules and arterioles that you don't see, but even those don't work the way that they're supposed to. So that increases the risk of problems from happening. The other big problem is the diabetic neuropathy, where the sensation is not enough, and there are a couple of different reasons as to why the sensation doesn't work properly. But not only the sensation, the motor function, the muscle function doesn't work normally. So the toes, instead of being flat, tend to curl up like this. When they curl up like this, then these things are pushing down against the shoe, the sole of the shoe or what have you, and again, more prone to injury and wound breakdown. So these are different examples of diabetic ulcers right over the great toe base, just from walking. This is an early one. This left untreated will go down to the joint here, and if it's still not treated, the patient will end up with an amputation. They start like this. I mean, just a little bit of callus, a little bit of skin irritation, that breaks down, further breakdown, all in the same foot. Right? So if we can catch it at this level or sooner, there are special shoes that we can use that prevent pressure over different parts of the area to prevent the breakdown from happening. If we catch it at this level, then there's wound dressings that we can do because, again, this is that stage 2 ulcer. It hasn't gone through the skin completely. So there's special kinds of dressings, the growth factors and things that we can do to kind of get that to heal. Once it gets to this stage, it's through the skin, down into the muscle, close to the bone. We need to go in, clean all that out, treat any infection that's there, and then get it to heal. Much more involved, much more complicated. So one of the things I always tell all of my diabetic patients is at least once a day, preferably twice a day, you need to look at your feet completely, front to back, side to side. And if you can't look at it directly, you can't bend your foot up to look at it, get a mirror. Get a good mirror and look at it. It's very, 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 very key. It gets boring, but the one time you miss something, and if you end up with something like this, and I'll show you an example of what happens if that is missed. Infection, as I mentioned, is the other big part after neuropathy and the circulation. So when we treat a patient with diabetes, we need to treat all of these problems. We can't treat the wound without making sure the diabetes is under control, without making sure there's adequate circulation coming to that area, without making sure the infection is under control. So we look at what's called a multidisciplinary approach. We have vascular surgeons looking at the circulation. We have infectious disease doctors looking at the bacteria, making sure we're treating it properly. We have plastic surgeons like myself doing the wound closure, skin grafts, or what have you, podiatrists looking at the toes and making sure that they're healing okay, so that we're treating the entire patient, not just one problem at a time. We're also doing serial measurements because it's very easy for us or even the patient to go, oh, it looks pretty good, it looks about the same as last week, maybe a little bit better, maybe a little bit worse, but we're not sure. By taking pictures, by taking measurements, so every time a person comes to the wound clinic, we do measurements. We say, okay, it's this wide, this long, this deep for each wound. And we measure, mark it, wound number 1, wound number 2, wound number 3, so we're able to track it scientifically as opposed to just looking at it and trying to remember from how it looked last time to see whether there is an actual improvement or not. And we have protocols. We say that a wound has to go down by 50% within 4 weeks. If it doesn't go down by 50%, then the next step kicks in, whether that's surgery to improve the blood flow or hyperbaric oxygen to try and get more oxygen to the tissue or what have you. But there's specific protocols so that we don't have people falling through the cracks in that situation. And then if we need to, as I mentioned, some of these more aggressive treatments, the skin substitutes, the growth factors, the negative pressure therapy or reconstruction or any of those things are something that we can do. Again, this is just an example of the different algorithms that we use depending on what the etiology is, whether we debride it, we look and see if there's an infection, we treat the infection or not, looking at where the problems are, whether it's with footwear, are they on the proper footwear, depending on what stage of the ulcer it is. So earlier stages, different kind of footwear, later stages, different kind of footwear. And for all of these, we need to make sure that we treat them effectively, but also prophylactically. As I mentioned, for all these wounds, the pressure ulcers, the diabetic ulcers, the venous ulcers, it's much more cost effective, much easier to treat them and prevent the wounds from happening than dealing with the wound once it happened. Simplest thing, it sounds simple, but for diabetics, if you can keep their blood sugar under control, it does a number of things. That's been shown to decrease the association with the vascular disorders, with the neuropathy. So you can feel your foot better, you can get your circulation to stay open much longer when your blood sugars are under control than when they're not. They found that when the blood sugars are above 200 and above 300, it increases the likelihood of developing diabetic nephropathy, neuropathy, and also the poor circulation by a factor 2 to 3-fold. And once the ulcer develops, one of the things that we find is, oh, it's really small, I'll just put some antibiotic ointment on it, see if it gets better by itself. And 2 weeks go by, 3 weeks go by before you end up seeing your primary care doctor, and then they try something else for another 2 or 3 weeks. Next thing you know, it's been 3 or 4 months since the wound started before we've actually started definitive treatment for this, because the definitive treatment means addressing each of those things that I talked about, the infection, the circulation, the blood sugar control, and all of those. So this is an example of a patient that had a little blister, didn't have a lot of open area. This thing would tend to scab once in a while and come off and close back up. Well, he finally came to the wound clinic. We looked at it and said, okay, we need to take this to the operating room to clean out this dead tissue because it looks more than what it appears to be. And after we cut it out, this is how much we had to remove. So the diabetic wounds especially can be very deceptive. What you see on the outside is really not what the problem is. It's really the tip of the iceberg as to what the problem is. So after treating this for a few weeks, we were able to get all the tendons covered, the wounds looking a lot cleaner, so then we did a skin graft and we were able to close everything up. But what theoretically could have been a short problem ended up taking 4 months to heal. And with the potential that that skin could break down again and be an issue again down the road. So it's very, very important as far as the prophylactic nature of what we do. Just to kind of quickly talk about the outpatient wound clinic that we have. Washington Hospital has an outpatient wound care clinic. It's been present for a little over 5 years now. Initially, we used to be at 1,900, relatively small facility at that time, 1,000 square feet or so. Last year, or early this year, January, we moved to our new location. The building actually right behind this building towards Walnut, corner of Walnut and Civic Center. and it's state-of-the-art, 3,000 square feet. We have 2 hyperbaric oxygen chambers, and we have physicians there 5 days a week, and it's a truly multidisciplinary specialty. We have plastic surgeons, general surgeons, vascular surgeons, podiatrists, infectious disease doctors, pretty much anybody that would need to be involved with wound care, with any of these complex wounds, we have. And all of the doctors meet usually once a month, sometimes even more frequently, to discuss difficult cases, so that if I'm missing something, one of the other doctors who's, say, a vascular surgeon would say, hey, well, you forgot to check about this, you forgot to check about that. So there's a lot of interaction. You also work with other doctors, not necessarily in the wound clinic, but diabetic specialists, physical therapists, venous disease, lymphedema clinic, primary care physicians, and we work with all of these to figure out what's the best way to get those wounds to heal. And one of the things we do is what's called failure mode analysis, which is by the time most of the patients that come to the wound clinic are referred to us, they've been through the mill. They've been through a couple of different doctors, a couple of different treatments, and nothing's worked, which is why they end up coming to us. So the first thing we do is figure out why it hasn't worked, what's missing. So we go back to the basics. We look at, as I mentioned, the host factors, nutrition, circulation, infection, and then we look at the local factors. How does the wound look like? What are the dressings that we're using? And then we kind of work our way up from the bottom and figure out what the cause of the problem is, and then treat it that way. And we've been pretty successful. We're part of Diversified Clinical Services, which is the largest wound care program in the country. And their healing rates are between 93 to 95%. We've been averaging about 97% at our wound center over the last year. So we're very proud of that. So again, in summary, there are multiple causes for wounds, whether they're diabetic wounds or any of the other chronic wounds that are available that we see. And there are multiple treatment options available. The key is to match the treatment options with the individual patient, because every patient is different. Every patient's got a different set of circumstances that's made that wound happen. So what we do is figure out for each patient what is their specific treatment that they need. So customize the treatment to the needs of the patient. And then we spend probably as much time educating the patient about how not to have this happen a second time around, because all of these patients, all of these wounds will occur again, because a lot of times the underlying problems, whether it's the stroke or the diabetes or the dementia, hasn't gone away. So we need to educate either the patients or the family to try and prevent that from coming back again. Thank you.
I saw honey was mentioned,
Yep.
and you didn't cover that. I was wondering what effect.
So honey has been found to be very, it's an antimicrobial. It kills bacteria because it's a very high concentration of protein in honey. It's very viscous, so it tends to dry up some of the tissues also. But it's worked very well in some of these chronic viscous wounds, and it's not honey out of the grocery store honey. It's Medi honey, same concept, but more purified, and it's been sterilized, so to speak, and they use that in combination to get rid of some of the more difficult wounds.
I have 2 questions. One, will any smoking prevent, wound healing like cannabis? There are people who are saying that, cannabis helps their asthma or whatever, glaucoma, whatever. And the second question is, how does a wound cause death?
I'm sorry?
How does a wound, bed sores particularly, because I've heard that with elderly, causing death?
Okay, so for the first question from cannabis, the short answer is yes, because in smoke there are other factors, whether it's not the nicotine itself, it's the carbon dioxide that's associated with smoke, it's some of the other particulate matter that's associated with the smoking that can cause constriction of the blood vessels and things like that, which decreases the blood flow. Nicotine also is a very powerful constrictor, so smoking cigarettes is worse than smoking cannabis, but smoking in general, because it has that carbon monoxide and some of these other particulate matter, does cause a decrease in the circulation. As far as death from wounds go, it's rare that a person will die because of a wound. A wound is a reflection of the general state of health of the person, right? So you can have patients who die from bed sores, but that's extremely rare. In the 20 years I've been in practice, I could probably say two hands, I could count how many people I would say, they died because of the wound. Because once you have an open wound, even if it were to get infected, it drains out. So the pus is not building up like it would if you, say, burst your appendix or your gallbladder or anything like that. But when you have somebody who has a chronic wound, as I mentioned, their nutrition's poor, they're debilitated, they're not moving, they have all these other issues that then increase the risk of them getting pneumonia or aspiration or some other of these other problems. Same thing with the diabetic ulcers. When I said, if you get an amputation from a diabetic ulcer, you have the same death rate as lung cancer. It's not that the amputation is going to make you slip and fall and die, but it's that if your care for the diabetes is so poor that you ended up with an amputation, then that care also reflects on poor circulation to the heart, poor circulation to the brain, more likely to get a heart attack or a stroke or some of these other issues that will culminate in death. But the wound by itself won't. But it's a state of your health.
For treatment of minor wounds, warm compresses, hot compresses, it seems to draw blood to the wound.
Well, so what we found is in the olden days, even when I was in training, the thinking was, if we let it dry out, if we let it scab over, it would heal better. And we found that wounds actually heal better in a moist environment than in a dry environment. So anything that will improve the circulation of that area, whether it's warm compresses or a moist dressing or anything like that, will help the healing. Now the key thing to remember is especially in, say, somebody like a diabetic or somebody who's had a stroke, where their circulation, where their sensation's not that good, if you have it too hot, and I've had patients who've had frostbite from putting ice on an area and not realizing it was too hot, or burns, thermal burns from a heating pad that they put on and fall asleep with, and they don't have sensation in that area. So you have to be really, like anything else, small quantities is good. If you do too much or if you're not careful with how you do it, it can cause problems.
How effective is the apigraph on certain kind of wounds?
It's extremely effective. So as I was mentioning, I think you may have missed that part. The growth factors, so apigraft is humans' cells that are actually taken from baby foreskin, and they're grown in a culture medium. And as they're grown, those cells grow into like a little sheet of tissue that we use as a graft. And those have been shown to have very high concentrations of growth factor. So when you apply it over the wound, right now Medicare approves it for diabetic wounds and for venous ulcers in the lower leg. They're extremely effective, anywhere from 2 to 5 treatments, and they close in the right patient, where the infection's under control, where the swelling's gotten under control, and we've done the prep work to get them ready for it. They have a higher than 80% success rate in closing those wounds.
I understand steroid creams are good for closed wounds but not for open.
Well, so steroids slow down healing, right? Whether it's you take it orally or you apply it topically, they decrease the ability for a wound to heal. And where steroids work is when you have an allergic reaction, when you have a rash, when you have a wound that's a little sensitive, there's an overgrowth of tissue. So the steroids are helping kind of decreasing that overgrowth. But when you have a wound that's healing normally, they really don't help, and I personally prefer not to use them. Now, as I mentioned, going back to that moist environment, we found that whether it's the wound or the skin dries up, that tends to either delay healing or make it more prone to breakdown. If you think about skin that's dried out, it can crack and break open and make it more likely that it'll break down. So I usually use any kind of lotion to decrease, to keep the skin moist so it doesn't break down as much.
What about Vaseline?
So Vaseline intensive care lotion's fine. I'm not a big fan of the petroleum jelly because the petroleum jelly tends to be more occlusive, and when it's an occlusive dressing, then the tissue can't breathe. And sometimes in some patients you can get a secondary fungal infection because it's too moist. Right.
I assume that having a good podiatrist is very important for people my age. The people who work with you, the podiatrists that you consult, do they all have practices here in the area and maybe could be contacted and engaged?
Yes. Yeah. So we have several podiatrists that we work with. We have one podiatrist that works in the wound clinic, and there are several other podiatrists in town, but we work with all of them. And if you call the wound clinic, and I think they gave the brochure that's got the number and anything, they'll be more than happy to give you a list of all the podiatrists that work in this area. And And then depending on the insurance and everything, they can kind of tell you, you know, who takes what insurance and such.